Hello, my dear future nursing officers. I welcome you all once again back to the master nursing classes where the most complicated things are made easy, and very easy for your better learning and better understanding and the better rank. Right? So, I welcome you all once again back to the master nursing classes. Dear aspirants, so very good evening to one and all. A very good evening to one and all. So I hope everybody's preparation is going very fine, and I hope you people are revising the content as per the plan. And don't forget to give the daily mock test as a priority. Okay, especially every Saturday, the live mains test and the from the Sunday to next Saturday again the prelims pattern test. That is very necessary for the exams to understand the real pattern and to understand the reality. Okay, so next I am going to give you a test, so that is with a timer. Definitely that is going to helpful for you all. Okay, so because if you are preparing everything and you are not matching your speed with the timer in the main exam, that is going to difficult for you all. Okay, so I will give the test, so that is with a timer practice. Okay, so I will update that one in the official WhatsApp channel, Telegram channel. If you are still not a part of that one, okay, so please do join that one. Okay, if you have the our app, okay, so do message in the chat box if you don't have the link, and you can directly join from the our description box of this video and the comment box of this video as well. Okay, yes, so we are going to start the session with this powerful motivational line. A very good evening to one and all. A very good evening to one and all. Namaste, Vanakkam, and I welcome you all once again back to this fruitful and the beautiful learning session. So that is for your better future and the best rank. Okay, yes. So let's begin the session without wasting a single minute of the time here with this powerful motivational line. I hope everybody are ready to get enter into this fireful session. So I hope everyone is ready. For do thumbs in the comment box. So I will start the session now, right? Yes. Hope video, audio, everything is clear. There is no problem. Okay, yes. So let's begin the session now without wasting a time with this powerful motivational line. If someone is asking you why you are solving the MCQs overnight, why you are revising the content overnight, and why you are waking up early, okay, to study, to prepare. So if someone is asking you like that, the just thing you have to replace, I have got a dream that is more worth than my sleep. I have my responsibility that is more important than my sleep. Yes, just sleep 6 to 8 hours per day, and remaining time completely dedicate towards your preparation. In a preparation, if you are preparing with a complete dedication, definitely you can reach your dream destination. So there no one can stop you to reach your dream destination if you are giving that time towards your preparation. Okay, so yes, our dream is having the more worth than our sleep. So you can compromise the sleep, but remember, you can sleep at least 6 to 8 hours per day. So then remaining time you completely dedicate to your preparation. Okay, don't compromise in the sleep. At least 6 to 8 hours. Okay, not more than 6 hours. No, sorry, not more than 8 hours. If you are sleeping more than 8 hours, so you are sleeping in your study time. So that is going to be a harmful. Okay, sleep 6 to 8 hours and remaining complete dedication towards the preparation. Okay, yes, so these all things we have done in the last class already. So that is the ng tube size. Quickly I will revise in the 10 second and I will move forward. Okay, ng tube size we have done in the last class. Okay, so for the infants 6 to 8 French, for the children's 10 to 12 French, and for the adult female 14 to 16 French, and adult male 16 to 18 French. It is same like a Foley's catheter. Okay, same like a Foley's catheter, right? Yes, sir. So here we have the color coding, everything we have done, and this table I have shown you. So this is the very important table. So I hope every one of you have revised. Okay, and I told what is the meaning of the French. So here the like 8 French, 6 French, 10 French. What is the meaning of the French? Meaning of the French is very simple. This is the tube means the outer diameter of this particular tube. So this French we will use for the saying the like you by like explaining the units of the NG tube also, catheters also, and suction tubes also. Yes, so the meaning of the French here is that is the outer diameter or the external diameter of the that particular tube, and one French is equal to 0.33. Now tell me 2.5 centimeter is equal to how many inch? Yes, how many inch? 2.5 centimeter is equal to, yes, the 2.5 centimeter is equal to 1 inch. So remember, so the question may comes in a twisted form. So they can directly ask you what is the meaning of the 1 inch, that is the 2.5 centimeter. What is the meaning of the 1 French, that is the 0.33 mm. I hope it is very much clear, right? So now tell me, 2.2 pounds means how much kg? Yes, 1 kg is equal to 2.2 pound. Okay, so this is the very important. So these are the units as a basic you have to understand here. Okay, and the next is how is the proper length of the NG tube is generally measured. I told the NG tube will be generally measured by the NEX techniques. So that is from the bridge of the nose to the earlobe, and from there to the xiphoid sternum. So this is the how we are going to measure the length of the NG tube. Okay, and here the most importantly, the most appropriate technique to measure the length of the godal area or oropharyngeal tube. So that is I told from the corner of the mouth, to the angle of the mandible. So this is very important. You have discussed yesterday's class, right? Yes, sir. So when inserting the NG tube, which of the following position is most likely used? So I told the two very important situations and scenario. While inserting the NG tube, sitting upright with the head slightly flexed, and while giving the feeding during the NG tube, means while giving the NG tube feeding, that time the semi-fowler's position. So that's the very important to be keep in our mind. Okay, so position during the NG tube feeding is the semi-fowler's position, and position during the NG tube insertion and removal is the sitting upright with a head flexed slightly forward, this position, right? So we have done this one in the last class, right? So the main very important reason for the semi-fowler's position during the feeding and after the feeding, we are going to maintain the same position because we want to prevent the aspiration. Okay, so this is to prevent the aspiration, right? Yes, here it comes to the today's class. Okay, yes, so try to answer to the question which is there in front of you all. Okay, I hope every one of you have seen this one in the last class only. Okay, this was the assignment question of the last class. Which of the following is the most accurate method to confirm the placement of the NG tube? So remember, to confirm the placement of the NG tube, the most and the gold standard technique and the most authentic method we have is the chest X-ray, and almost all you people given the correct answer. So that is the chest X-ray. So this is 100% is correct answer. Option A is telling visual inspection of the tube position. Yes, we will visually inspect the tube position. Okay, so at least 50 centimeter and more than the 50 centimeter of the tube should be inside the body. Yes, that is also a technique, but this is not in the confirmatory technique, or this is not a most accurate technique. Okay, then option B is the measuring the tube length. So measuring the tube length is not going to determine the position or the placement of the NG tube. Next we have the aspiration of the stomach content and checking the PS. So this is also a method of the checking the placement, but it is not in the most accurate method. Okay, in the question they have asked the most accurate. So most accurate goes to the chest X-ray. So then most common, which one, sir? Most common and routine. If the examiner is asking the routine method of the checking the placement of the tube and the most common method is, so every time we can't send the patient for the X-ray, because X-ray is for the first time we inserted the NG tube and we are going to confirm the position of the NG tube. So that time the gold standard one is the X-ray. We are going to take a X-ray. But every time we are like we have to check the placement of the tube. Every time before the feeding we must and we should check the placement of the tubing. So every time we can't go and check the X-ray, right? So that is the reason the most common method and routine method is the aspiration of the gastric content and check the pH. Okay, so this is the most commonly every time you are giving the feeding. Before the feeding you have to check the placement of the tube. Okay, so every time we can't go for the x-ray, so the routine method we have is the that is the aspiration of the stomach content and check the pH. Okay, so how we are going to confirm the placement of the NG tube? So you can check the confirmation of the placement of the NG tube. That is by the most reliable method we have is the that is the gold standard method we have is the that is the X-ray of the abdomen. X-ray of the abdomen, right? Yes. So this is a content from your plan A1. Okay. So next is the bedside methods we have. So that is the aspiration of the gastric content. In the aspirated gastric content, so we are checking the pH of the that content. You know, the content which is there in the stomach, which is a predominant and fully dominated with a HCl, that is the hydrochloric acid. So hydrochloric acid having the acidity. So acidity means completely the pH will be less than 7. Okay, so the pH will be less than 7. So here it is the more acidic, means the pH will be more acidic because of the hydrochloric acid. So whenever I am checking the pH of that gastric content, if the pH is less than 5.5, so it is in the stomach. If it is more than 6, that is in the intestine. If it is more than 7, the tube will be there in the respiratory tract. Remember, so the content we aspirated, in that one we are checking the pH. pH is less than 5.5, the tip of the NG tube is in the stomach. pH is more than 6, the tip of the NG tube is in the intestine. And the pH is more than 7, the tip of the NG tube is in the respiratory tract. So this is very important to be keep in our mind. Okay, and whatever the content we aspirated, that one we are going to check the color of that content. Okay, usually that should be a greenish or the clear color content it should be. Okay, and we are going to observe. So what we are going to observe? We are going to observe the tube. Sir, what we are going to observe in the tube, sir? So how much centimeter of the tube is present inside the body? I told more than 50 centimeter. That is the 50 to 55 centimeter of the NG tube should be inside the patient body. So this is very important. Then only we will consider it is there inside the stomach. Okay, and we are going to check with the air bubble method. Sir, how we are going to check with the air bubble method? So consider this is the NG tube we have. So here we have the NG tube. We can see this is the NG tube we have. This one we call as in the tip of the NG tube. Okay, so this is called as the tip of the NG tube, and this one is called as the base of the NG tube. So what we can call this one as in the base of NG tube. Okay, so here we are going to insert this NG tube inside the stomach, and this tip should be in the stomach. Okay, that time we are going to dip this base in the a bowl of the water. Okay, so base, whenever we are dipping in the bowl of the water, so there is no any air bubbles coming in the bowl of the water, means it is not in the lungs. If the tip is in the lungs, so we are keeping this a base in the bowl of the water, so air bubble will be generated in that particular bowl of the water. So the base is in a under the water, so that time bubbles are created means the tip is in a lungs. Bubbles are not created means tip is in a not lungs, it is in a our GI system, that is in the stomach. Okay, because if it is in the lungs means what happens? If it is in the lungs means the air will come out of that our NG tube. So insert the base of the NG tube in a bowl of the water, and no air bubbles means tube is in a stomach. If the air bubbles are present means tube is in the lungs. So this is very important. Okay, and after insertion of the NG tube, patient should not be having the continuous cough or the respiratory distress. If the patient is showing some continuous cough and the respiratory distress, which clearly indicates the tip of the NG tube is entered inside the trachea. Okay, and previously we used to have the whoosh method or the air insufflation method. So what is the whoosh method or air insufflation method, sir? So that is, you can see, so we are going to, this is the patient you consider. Okay, and this is the patient you consider. Okay, and here we have the head of the patient. Okay, here it comes to the nose of the patient, right? Yes, sir. So you consider this one is the stomach of the patient, and here we have the esophagus, which is connected to this one. Okay, yes, sir. and here it comes to the our NG tube, right? Yes, sir. So here at the base of the NG tube, we are connecting a syringe, so which is loaded with the air, and here the tip of the NG tube is in a stomach. So here we are going to keep on stethoscope, and we are going to push the air suddenly here, and we are going to listen the sound here. So that is what we call the air insufflation method, or the whooshing tip. Okay, so whooshing test. So now whoosh test or the air insufflation method is not recommended, but this is also one method where we can confirm the presence of the NG tube. Okay, so here we are pushing the air, here we are pushing the air, and here we are listening the sound with the stethoscope, means the tip is in the stomach. We will confirm with that one. Okay, so this is important for the exam, so please do keep in our mind. So this is called as the whoosh technique, or the air insufflation technique. This technique is nowadays not recommended, so just for your knowledge purpose you can remember this one. Okay, yes. So here it comes to the next very important question. So that is this: which of the following is the nursing responsibility after administering an NG tube feeding? Dear aspirants, I am taking some clinically important questions and the clinically little bit challenging questions, and even those are the easy or the medium or hard questions I am discussing little bit in detail, because this one will build your concept. Now you guys not require the advanced level of the knowledge. Now you guys require the re-enhancement of the knowledge which we have already inside you. Just my work here is to, I have to remember you that you know the everything, and that confidence is going to strike in the exam, and the result is going to come. If I want, I can stretch this class to more than 3 hour, 4 hour, 5 hour, and I can waste your time. So that is going to waste your time, not to improve your performance. So the main target is here is to improve your performance and the confidence and the rank. Okay, so that is the main target of these classes what I am hitting here. Okay, so here these questions may comes with a complete like same to same questions with the same to same options may strike in your exam. Yes, so that is going to give the extra marks, and the same concept what I am teaching, that is going to strike in your exam, that is going to boost your marks. Yes, so studying everything is not important for the Norcet. So for the Norcet, studying the thing which is required for your exams, and where the examiner is interested to ask the question, that thing we must and should cover. Okay, so that's the main target of these classes. So just enjoy the classes and be completely involved in the answering of the questions and understand the technical terms. If I ask the simple questions, you can easily answer. Can we check that one? So leave over this question. I will check your knowledge level now. Just okay. So I will. I'm telling that the thing you know everything already. Just you have to believe on you. Okay. So let me check that one. Okay. So I will ask some simple questions and try to answer that one. What is the smallest bone in our body? The smallest bone in the body. Smallest bone in the body, that is the stapes. You know that one. What is the normal intracranial pressure? What is the normal intracranial pressure? That is the 5 to 15 mm of Hg. Right? What is the normal intraocular pressure? What is the normal intraocular pressure? That is the 10 to 21 mm of Hg. Right? Yes. And what is the longest bone of the body? Longest bone of the body is the femur. So these kind of the simple questions you guys know from your first year of the BSc nursing only, right? Yes. So now my purpose of taking these scenarios and practical based question here is, you people should feel that you are a nursing officer and working bedside, and you feel that you are performing that particular procedure and you involved in that one, and you answer to the scenario based and the procedure based question. So then it will definitely give you a correct answer. So be in a rhythm of the nursing officer. You feel you are already a nursing officer, then half of the question will automatically will get solved. Okay, so you guys not require the simple questions, that is definitely you know, and if even I am teaching, or if even I am not teaching, that is going to make you correct. So I want the questions where I am teaching, and that is improving your difficult question also you are making correct, so that is going to decide your rank. So I want that one, and I am building that one. Okay, yes, it doesn't mean I am not discussing the basics. I am going with the basics so that you can solve the basic questions also, and you can solve the advanced questions also. Okay, so just believe in yourself, you know the everything, and you will give the best shot in the exam, right? Yes. So here it comes to the question: which of the following is the nursing responsibilities after administering the NG2 feeding? So we have done the NG2 feeding here. So after the NG2 feeding, what is the nursing responsibility is the question. Option A: leave the patient in a supine position for 30 minutes. If we are leaving the patient in a supine position, what is going to happen? After feeding, I am keeping the patient in a supine position. So here the risk of the aspiration will be there. So can we able to do? We have to do this one? No, this is not to be done. Okay, so because it will increases aspiration risk. It will increases the aspiration risk, right? Yes, sir. So this one we are not going to perform. Sir, then which position we have to give, sir? So that is the head of the bed elevated position we have to give, not the supine position. Okay, yes, sir. Then comes to the option B. Flush the tube with 30 ml of the water to ensure it is clear and patent. Yes. So this is 100% thing we are going to perform. So we are going to flush the tube with a 30 to 50 ml of the water. So where it is going to clear the entire NG tube. Okay, NG tube we are inserting to give the feeding not only for the one time. So by that particular same tube, I will give the morning feeding also, afternoon feeding also, evening feeding also, night feeding also. And in the morning I have given some feeding and I have not flushed the tube. So whatever the food I have given, it is get stuck in the tube, so it will not go inside. So whatever the feeding you are giving afternoon, so that will not go inside, right? So that is not going inside means that is very difficult to the like healthcare providers to give the feeding, and that is difficult to the patient as well, because it is get stuck means we have to remove that one, and we are going to reinsert the NG tube. So that is the new procedure again we are going to do, right? Yes. So that is the reason, in order to avoid the multiple NG tube reinsertions, so every time we are going to give the feed means that before the feeding and after the feeding, so must and should flush with the 30 ml of the water, and to keep the NG tube completely clear and patent for the next use. Getting the point? Yes, sir. Next comes to the option C. Immediately change the feeding tube. No. Why we are going to change the feeding tube? So feeding tube should not be changed immediately. Okay, especially consider the NG tube you are giving the feeding. So through the NG tube, you are not going to change very frequently. Okay, so NG tube like it should not be changed very frequently. And if you are giving the continuous feeding, intermittent feeding, IV tubings, so that's the feeding tube, so you can must and should use for the at least 24 hours. Okay, so after 24 hours, I am not talking about the NG tube, I am talking about the feeding tube. So this is, you can see, this is the our gravity bag, this is our gravity bag, and this is our NG, this is our feeding tube, this is our feeding tube. Okay, and here we have, this is our NG tube. So this is our NG tube. So NG tube, once you inserted means you can use for the 14 days, 15 days also you can use. Okay, there is no any like minimum and maximum guidelines to use, like there is no standard guidelines. So based on the need of the patients and based on the situation of the NG tube, so that we are going to see whether we are going to re-perform it or whether we are going to continue it. Okay, that is based on the situation, right? But it should and it must. So these particular tubings, this is the feeding tube. Okay, so this is the feeding tube, so we are going to use in a continuous or intermittent feeding. So this feeding tube we must and should change for the every 24 hours. Okay, it should be changed every 24 hours. Okay, this is very important. Means every 1 day we are going to change the one tube. Okay, and here we have the gravity bag. This one is the gravity bag. This gravity bag should be changed again every 24 hours. Okay, this is also used for only for the duration of the 24 hours. But the question will comes on the flushing of the gravity bag. So how the question will be arising here is, so the change of the gravity bag and use of the new gravity bag to be done after 24 hours, and the flushing of the gravity bag will be dependent on the two types. Okay, so which type of the feeding we are giving. If we are giving the continuous feeding, if we are giving the continuous feeding, so in the continuous feeding, that is every fourth hourly, I am going to flush this particular gravity bag or the feeding bag. Okay, and if we are giving the intermittent feeding, in the intermittent feeding, so I am going to flush this particular gravity bag every time before feeding and after feeding. Okay, so every time before feeding and after feeding I am going to flush this particular gravity bag in the intermittent feeding, and in the continuous feeding every fourth hourly. So why we are going to flush every fourth hourly here? So this is in order to prevent the growth of the bacteria. Okay, so if you are giving the feeding, okay, and we are not flushing, means so that is encourages the growth of the bacteria, so that may enters through the our tubing directly into our body, so that we don't want, and flush it every fourth hourly in the continuous feeding, and in the intermittent feeding, so that is to be flushed every time before the feeding and after the feeding. Okay, and the tubing should be changed every 24 hours once, and the gravity bag should be changed every 24 hours once. Okay, so then comes to the option D here, remove the gravity bag after the feeding and discard. No, so the remove gravity bag we are not removing and discarding after the feeding. So this one we are using for the duration of the 24 hours. Okay, after 24 hours only I am going to discard this one. Okay, so not every time, right? So this is, I hope it is very much clear to everyone of you, right? Remember, flushing. So flushing frequency to be keep in our mind. This is before and after each feeding in the intermittent feeding and intermittent medication administration. So every fourth hourly during the continuous feeding. So these are the two very important points. And typically how much amount of the fluid we are going to use to flush, that is the 30 to 50 ml amount of the fluid or the water we are using to flush, and the feeding bag what we are having, so that is feeding bag or the feeding tube to be changed every 24 hours. So this is once a daily we are going to change. This is very important points to be keep in our mind. Okay, and here it comes to the image based questions of the, so this is our nasogastric tube. So we also call this one as the Ryle's tube. So this is the most important image based questions you may get in your exam. Okay, so here it comes to the next question. So I want everybody's complete and perfect answer. Okay, so for do mention your answer in the comment box. It is the again the simple concept based question. Yes, फटाफट. I want answer from the everyone of you, everyone who are watching now live. So I want answer from everyone of you. फटाफट do mention your answer, whether it may be correct or wrong. Yes, it is a simple and multiple time we have given this question in your daily live practice. Okay, so that I hope every one of you have already seen this question and already you know the rationale behind this one, right? So who all are don't know, listen carefully, this is very important. Okay, so which acid base balance is commonly seen in a patient undergoing the prolonged NG tube suctioning? So patient is now under the prolonged NG tube suctioning. So means patient may having some gastric disturbances, and we want to keep the NG like stomach completely decompressed, and we have inserted the NG tube and we have attached to the drainage bag continuously. The NG tube suctioning means the complete gastric content which is there, which is coming out through that particular NG tube. Okay, so this is what we are doing here. So that's the NG tube suctioning means. So all the content which is there in the stomach which is coming out. So what is the acid base imbalance happens due to the prolonged NG tube suctioning is the question. Yes, so that is what happening here in the NG tube suctioning. So the acid is going to loss. Acid is going to loss from the body means what is going to happen? the pH is going to increase, H plus ion is going to decrease. Okay, so acid is lost means H plus ions also lost, and pH is going to increase. pH is going to increase means metabolic alkalosis will happen. Sir, how, sir, we didn't understand this one? Yes, let me explain the concept. Okay, so now you tell me what is this? This is the esophagus. What we call esophagus, also called as the food pipe. What we call this one? This one is called as the food pipe. Okay, and in front of this one we have the trachea, that is the wind pipe. Okay, so this is the esophagus, and here we have the J-shaped organ which is responsible for the reserving the food, so that is the stomach. So what we have here, so this one we have is the stomach. Okay, so this is what we have, the stomach, right? And here we have the intestine. So here we have intestine. Okay, yes sir. So this one, I hope you are very much clear. So you know, inside this particular stomachs, so there is an acid, we call that one as the hydrochloric acid. Okay, so that is the HCl. So because of this HCl, the pH of this stomachs is completely acidic. So because of this HCl, the pH of the stomach is completely acidic. So now what we are doing, we have inserted the NG tube in this one, and we are performing the suctioning. Means this all the content which is there here along with the this particular HCl. So everything we are taking out. Means HCl is came out of the body. HCl is came out of the body. Now HCl is came out of the body means the acid is came out of the body. Okay, so now the acidic content which was there inside the body, that is also came out of the body, right? So now acid is lost from the body, which means acid lost from the body, it means so H plus ions also we have lost from the body. So H plus ion is going to decrease. Wherever the H plus ion is going to decrease, so where our pH is going to increase. Okay, so pH is going to increase. Now what happened, the pH is increased and H plus ion is decreased. Okay, so pH is increased, H plus ion is decreased. So when the pH will be increased, so what we can call that one, we call that one as the alkalosis. What we can call that one as we call that is the alkalosis. Okay, this is very important to be keep in our mind, right? Yes sir. So here alkalosis happening due to the metabolic problem, not due to the respiratory problem. So this one we call as the metabolic alkalosis. Okay, so if it is any problem with the respiration, so that is the excessive elimination of the carbon dioxide, that will cause the respiratory alkalosis. Here due to the loss of the HCl and the H plus ions, so here we are having the metabolic alkalosis. This is very important, we have to keep in our mind, and this is important for our future exams. Okay, yes sir. So now we understood. So we will be having the alkalosis, that is which alkalosis are metabolic alkalosis. And I hope every one of you know this particular gastric content which we have here, this is very much rich in the potassium also, this is very much rich in the chloride. So because of the chloride only hydrochloride is forming, and this is rich in the sodium also, especially the question will strike from the potassium. So in a continuous gastric suctioning through the NG tube, which electrolyte is going to be lost more? So electrolyte which is going to last more is the potassium. So there is in the chance of the hypokalemia. Okay, yes. So in a hypokalemia, what is the classical ECG finding? So in a hypokalemia, classical ECG finding which we have is, yes, so that is flat or inverted T wave. Okay, flat or inverted T wave. This is the very important ECG finding which will be there in the hypokalemia. When the hyperkalemia, that is the tall T wave will be there in the tall T wave, that is in the hyperkalemia when the potassium is increased. Okay, in the hypokalemia, the flat or the inverted T wave will come. Sir, why you are teaching the ECG in this one, sir? Understand. So the scenario will be formed in the exam. So like this, the patient is on the continuous or the intermittent gastric suctioning, and so we have sent the patient for the cardiology consultation with due to the cardiac problem in the patient. Okay, and the cardiologist advised the take a ECG. So when we have taken the ECG, so we have got that the patient T wave is inverted or the T wave is flat. what you are going to suspect. So option A, due to the primary cardiac problems. Option B, due to the electrolyte imbalance, that is due to the hyperkalemia, and due to the electrolyte imbalance, that is due to the hypokalemia, may be the options here. Okay, so what is your answer? So here your answer should be, this is due to the electrolyte imbalance, that is due to the hypokalemia. So why? Because when the potassium will decreases, T wave becomes flat. When the potassium will increases, T wave become tall. Okay, so please do remember. And here the hypochloremia happens, hypokalemia happens, and hyponatremia happens, and the alkalosis happens, metabolic alkalosis. Along with this one, the dehydration risk will be more. Okay, yes sir. So not only in the gastric suctioning, same concept will happens when the excessive uncontrolled vomitings also. Okay, so excessive uncontrolled vomiting is there. Again, here in the suctioning we are removing through the tube, and in the vomiting it will come automatically. So in the vomiting, HCl will be lost. So again, alkalosis, that is the metabolic alkalosis, and the hypokalemia and hypochloremia, and the like the sodium is going to last. So that is the hyponatremia will happen. So this is the very important to be keep in our mind. Okay, yes sir. So I hope it is very much clear to every one of you. Yes, during the uncontrolled excessive vomiting also same problem, and in the gastric suction also same problem. And here it comes to the, now consider the patient is having the excessive diarrhea. So this intestine, which is having the completely rich in the alkaline fluid and the alkaline mucosa. Okay, in the diarrhea, this entire alkaline fluid and mucosa which is there here, so this will be get lost. Okay, this will be get lost, so this will be come out of the body, right? So now this particular a very important a content in the intestine which is rich in the our alkaline, so this is coming out of the body now. So the alkaline is getting lost from the body, so alkaline is coming out of the body, which means the H plus ions, what happens? H plus ions is going to increase. Okay, H plus ion is going to increase means what happens to the pH? The pH is going to decrease. Okay, so when the pH is going to decrease, so what happens? This is the acidosis or alkalosis. So this is the acidosis. Okay, so this is the acidosis, right? Yes sir. So here the acidosis will happens in a case of the diarrhea, and alkalosis will happens in a case of the gastric suctioning and vomiting. So please remember concept, basic concept. In a case of the diarrhea, there is an acidosis due to the loss of the alkaline mucosa and due to the loss of the bicarbonate also, because the intestinal mucosa is having the bicarbonate as well. So here we are going to give the a very important oral rehydration salt. In the oral rehydration salt, we are having the citrate. So that citrate we are going to treat this particular acidosis. Sir, how citrate is going to treat the acidosis? When the citrate will get metabolized, so that will get converted into the bicarbonate, and the bicarbonate is the thing which will neutralizes the acid. So, and the most importantly, how to keep in our mind, bicarbonate, that is the sodium bicarbonate, is the drug of choice for the metabolic acidosis. Okay, yes, comment in the comment box. What is the drug of choice for the metabolic acidosis? What is the drug of choice for the metabolic acidosis? The very important thing to be keep in our mind. Injection sodium bicarbonate. Okay, so that is the drug of choice for the metabolic acidosis. Okay, so what education you will give to a patient who is having the respiratory alkalosis? What education you are going to give to a patient who is having the respiratory alkalosis as a treatment option? Option A, deep inhale breathing and exhale forcefully. Option B, stop the breathing. Option C, use a paper bag for the breathing. So cover your mouth and nose in the with the paper bag and breathe in. And option D, go to the area where there is on the high concentration of the oxygen is there and breathe. So what is your advice in a patient who is the respiratory alkalosis? Yes, we are going to advise the paper breathing for the paper breathing for the respiratory alkalosis cases. Okay, so because we want to send back the carbon dioxide back into the body, so we will give one paper bag and we will cover like this. Okay, the patient will exhale the carbon dioxide and he will inhale that same carbon dioxide again back. So that is the reason we are going to advise the paper bag breathing for the respiratory alkalosis. Okay, yes, is that clear? Yes, well done. So here it comes to the, we will come back to the our question. So the answer for this one will be, I told already, a prolonged NG tube suctioning or the uncontrolled excessive vomiting, the metabolic alkalosis will happen, and in the case of the diarrhea, the metabolic acidosis will happen. Okay, and if the patient is having the COPD, asthma, or any other respiratory conditions, so that time respiratory acidosis will happen when the patient will be having the hyperventilation, so that time the respiratory alkalosis is going to happen. Okay, yes, is that clear to every one of you? Is that clear? For do thumbs up in the comment box. Is that concept what I told to every one of you is clear? Do thumbs up or write yes sir. So we have the lots of the concept to discuss today, so that is having the highest chance to strike in the exam. So the direct questions may comes, may not comes, but the concept what I am teaching now in this today's sessions is the very brilliant concept. So that is you must and should know for the exams, and that is as a revision for your exams, because this concept we have already covered in detail, in perfect, with images, every point, every minor and the major and advanced and the updated points we have already covered in the A1 plan, right? So this is just I'm remembering that we have already done, and I'm just remembering the concept. So this is the real way as we have to approach to the MCQs. Okay, so yes, so this is the very important to be. Yes, I hope it is clear. Then it comes to the next question. Here is the next question. The Seldinger technique commonly used for central line insertion, which involves, what actually mean by the Seldinger techniques? So first and foremost, the question may arises from the question itself. Which technique we are going to used during the central line insertion? So this may be the question. So the which technique we are used for the central line insertion? So the Seldinger technique is the technique where we are going to use for the central line insertion, right? Yes sir, right. So what is the meaning of the Seldinger technique is the question. So what is the meaning of the Seldinger technique is the question now. Okay, the Seldinger technique commonly used for CVP insertion. What it actually involves? Option A, directly puncture the vein with the catheter. We will take a central line catheter and we will directly puncture like an IV cannula, we will insert. No, this is the wrong method. So this is the wrong method and this is not a Seldinger technique. Okay, then comes to the option B. Insert the guide wire followed by the catheter replacement. The perfectness, the very perfectness is there in the answer. That is, first we will insert the guide wire. With the help of that guide wire, we will insert the catheter. So that's very important. Okay, yes, sir. This may be the right answer. So I will choose this one for the current, and I will move forward and I will read other options also. Then option C we have here. Use of the surgical scalpels to create the incision. No, surgical scalpel we are not using to create the incision. Just we are taking a needle and we are inserting the needle. Through the needle, I am inserting the guide wire and I am taking out the needle. Through the guide wire, I am inserting the CVP land. So I will teach with the complete explanation. Just remember, okay? So just understand, we are not using the surgical scalpel for the creation of the incision. That is the wrong statement. Then comes to the option D. Injection of the contrast dye for the imaging. No need of the contrast dye during the insertion of the CVP. So this is also wrong option. Okay. So here we have the Seldinger technique, and understand what we are going to do in the Seldinger technique. So this is our right internal jugular vein. Okay. The most common vein used during the insertion of the central venous pressure is the right internal jugular vein. So that is the RIJV. Okay. Yes, sir. So you consider this is the now right internal jugular vein. Okay, so insert this right internal jugular vein. I am going to insert the central venous catheter now, and I will try to insert that with more practically. You have to try to understand this one. Okay, so how we are going to insert in the Seldinger technique? Consider this one is the needle which we have Okay, this is the needle. This is the needle we have here. Okay, yes sir. This is the needle. I will take this needle first. Okay, and with the help of this needle I will prick this needle into the vein. Okay, I will prick this needle into the vein. So now I have punctured the vein with the help of the needle, right? Yes. So with the help of this needle I am going to insert the guide wire. I am going to insert the guide wire. I will take a guide wire in another color. So this is the guide wire you consider. Okay, now I have inserted the guide wire inside with the help of this needle. So now I use the needle to prick and I have inserted the guide wire through the needle. Now I am going to remove this needle. Okay, so I am going to remove this needle. Okay, yes sir. So now inside the vein I have the guide wire. Now I will take the a very important CVP catheter. Okay, so consider this is CVP catheter. Okay, so this is not CVP catheter, just consider for the temporary purpose. Okay, I will show you how the CVP catheter also looks like. So I will take a different color. So I will take red color. Okay, so consider this one is the CVP catheter we have. Yes sir. So this CVP catheter I am going to insert through this guide wire. So with the help of this guide wire it will easily enter into the our vein. So then I am going to take out this particular guide wire. Okay, I am going to take out this guide wire. Okay, so this is now I have fixed the central venous catheter in the our very important central vein. So this is how we are going to use the a Seldinger technique to insert the our central venous catheter. So this is very important, right? Yes. So I hope it is very much clear. Just understand which technique we are using here. That is the Seldinger technique. Okay, that's the Seldinger technique. So I hope it is very much clear, right? Yes. And here it comes to the next question. The most commonly used site for the central venous or the central line insertion in the adult patient. Yes. The most commonly used for the central venous line insertion in the adult patient. So that is the a very important right internal jugular vein. So we have discussed this one multiple times. So I don't want to waste your time here because we will discuss the more important concept on this one. Okay, so that is in detail because from here the question will strikes, because this is the most commonly used site for the central line insertion. Means we are going to discuss little bit in depth about this one because this is our examiner favorite. Okay, sir, why right internal jugular vein is the my question. Sir, why not left? Why only the right? So first and foremost thing, we are going to create a base here where we are going to insert the tip of our central venous catheter. CVP line is there, or that CVP line catheter tip should be placed in which area? So this is our heart we have. Okay, so this is the heart we have, and here it comes to the four chamber of the heart. These are the four chamber of the heart. Okay, so this is our right atrium. Okay, and this is the superior vena cava, and this is the inferior vena cava. Okay, yes sir. So I am inserting the central venous catheter by the right internal jugular vein. So from the right internal jugular vein it will come to the brachiocephalic vein. From the brachiocephalic vein it will comes into the our superior vena cava. So where we are going to place the tip of the our a very important central venous pressure catheter. So this is the central venous pressure catheter which we have here. The tip should be this one. So where it should be placed? The tip of the central venous catheter to be kept at the lower 1/3 of the superior vena cava. Lower 1/3 of the superior vena cava. Sir, I don't want this whole thing. I want the only thing which is examiner favorite. So that is, I am going to say this is the right atrium. This is the vena cava. So this is the junction between the right atrium and vena cava. So I call this one as the cavo-atrial junction. What I can call this one as the, so I can call this one as the cavo-atrial junction. So why? Because here the most importantly the superior vena cava and the right atrium is meeting together. So that's the cavo-atrial junction. So the tip of the our central venous catheter should be in the cavo-atrial junction. Right? So which side which is there, sir? That is the right side which is there. Right? So understand, from here this particular superior vena cava, what we have, this one will further divided into the brachiocephalic vein. Okay, so that is the brachiocephalic vein. So that particular brachiocephalic branch is going to give right and the left branch. So that we are going to discuss now in the next. Okay, so in the next slide. So just now we understand this much here, otherwise we will get confused here. Okay, so the most preferred one is the right internal jugular vein. So why it is most preferred means, so that is you have to consider here, the right internal jugular vein is the completely straight and it is direct jugular vein which we have. There is no any bend is there. Okay, and it is direct to the our heart, that is especially to the right heart, and this will provide the most direct access to the right atrium. So there is no any like bend coming here and bending, then come and then go to the right heart. It is not like that. We are inserting from the right side, directly it will comes to the right heart. So if there is no bend, then we are monitoring the CVP, so it will give the more accurate result, so that at the right side. So if it is bending, it means it may give the wrong result also. So that is the reason always go for the right side internal jugular vein. So because it is straight and whatever the pressure exerted on the our right internal jugular vein catheter, so that one we will consider as the most accurate CVP measurement. Okay, this is the very important to be keep in our mind. Okay, yes sir. So why right only means it is the straight and in direct contact with the like hearts, especially right heart, and it will most direct and in a contact with the right atrium, and it will give the more accurate CVP value. So that's the very important, right? Because it is not bended. It is not bended means there is no any low or high in the CVP value. So it will give the exact measurement of the CVP value. Okay. So how catheter will reach the right atrium when we will insert through the right side internal jugular vein. So you understand here. Here we have the superior vena cava. This is the right heart, and this is the superior vena cava we have here. Let me take another pen here. So I will take a yellow. Okay, so this is our superior vena cava we have. Okay, this superior vena cava is now divided into the left side brachiocephalic vein and the right side brachiocephalic vein. Okay, yes sir. Superior vena cava is divided into right brachiocephalic and the left brachiocephalic. Next, this particular brachiocephalic which we have here, this is divided into the subclavian vein and the internal jugular vein. Subclavian vein is first below the clavicle, and the internal jugular vein is going to pass through the our neckline here. Okay, so if I am inserting the central catheter like this, so you consider this one is the central catheter. So what I am inserting the yellow line. Okay, so it will directly comes to our heart, right? There is no any bend. If I am inserting from the left side internal jugular vein, so it will comes here, then it will have to take the bend here like this, then it will comes to the heart. So it is having the bend, so that we don't want, and here it is coming very straight, so this is what we want. Okay, so it is coming very straight means it will give the best accurate method result. Getting the point? That is the reason for the monitoring of the CVP, the best one will be the right side internal jugular vein. So I hope it is very much clear to everyone of you, right? Yes sir. So then how it is reaching to the our right atrium? So first we insert into the right internal jugular vein, then it is coming into the brachiocephalic vein, then from the brachiocephalic it is coming to the superior vena cava, from there to the right heart. Okay, so this is the flow chart, and this was asked in the previous exam. That is right internal jugular vein to the right brachiocephalic vein, and from the right brachiocephalic vein into the superior vena cava, from the superior vena cava into the right atrium. So these are the important and the very important for the exams. Okay, so next here comes to the our image based question. So this is our, what is this? So this is there in the today's mains test as well. Okay, this image, it is there in the today's mains test also, right? What is this? I hope today's mains pattern test every one of you have given in the master nursing classes. Yeah, in the it was given to all of you. So that is to the rank booster test subscriber also. plan A1, that is from the basic to advanced preparation test series plus classes batch also, and to the A2 batch, that is where already your entire syllabus is completed and you want the best questions practice in that particular batch, that is the A2 batch also. We have provided the mains test. Okay, so today is the mains pattern live test. So after the class, who all are not attended, go and attend the mains test. Okay, and try to share your marks, so how much you are getting to my telegram, okay, or to my WhatsApp. So I will guide according to that one, so how what you are making the mistakes, and if whatever the possible thing I can do from my side. Okay, yes, so do attend without failure and update your scores to me, so that I can help you and I can guide you accordingly. If you are going right, so I will say you are in the right position and you go as soon as the same. And if you want any corrections, I will do the things which is required to you, and I will suggest the thing which is you have to follow for the cracking the mains exam. Okay, yes, don't forget to give the today's mains test, right? Yes, here it comes to the very nice. So this is the our central venous catheter. So this is our central venous catheter. Okay, sir, what are the purpose where we are going to insert the central venous catheter? So we have the various purpose. Okay, so what are the purpose we have to insert the central venous catheter? So we can insert this one to give the total parenteral nutrition. We can insert this one to give the chemotherapy. We can insert this one to monitor the central venous pressure. We can insert this one to collect the samples also. So means not routinely in a critically ill patient. Okay, so in a critically ill patient only we are going to insert the central venous catheter. So it is not required for the all routine patients. Okay, so this is the central venous catheter we have. And the question is, so here we have the 3 lumens. Okay, so here we have the 3 lumens, right? So these are 3 lumens: lumen number 1, lumen number 2, lumen number 3. Okay, so in this one, this smallest length one, so this will open at the last here. Okay, so this is open at the last here, and this one I am going to call as the distal lumen. So what is this one, sir? This is the distal lumen. Okay, yes, sir. And we have this middle length one. Okay, so this is going to open here. This one I am going to call as the median lumen. Okay, this is I am going to call as the middle or the median lumen. Okay, right? Yes, sir. And here we have, that is the most lengthest one, so that will opens here. This is called as the proximal lumen. So this is called as the proximal lumen. Okay, yes, sir. So this distal lumen, medial lumen, and the proximal lumen, we have the 3 lumens. Which lumen is used for the which thing is the examiner favorite question and asked question in the previous Norcet exams, right? So now tell me, here is the our right heart, on which lumen there is in the direct pressure is coming, on the proximal, medial, or the distal? Yes, here is the right heart we have. This tip will be in the our cavo-atrial junction, and from the right heart, which lumen is getting the direct pressure? So that is the distal lumen is getting the direct pressure from the heart. Okay, so the direct pressure from the right atrium, which is directly excreted on the distal lumen. So this particular distal lumen is used for the CVP monitoring. This is the examiner favorite question and asked question already in the exam. So please do remember this one. Okay, yes, sir. So that is which lumen is used for the CVP monitoring? That is our distal lumen. And always the lumen which we are using for the TPN is the median lumen. The TPN lumen is always used for the our the median lumen always used for the TPN purpose, and the proximal lumen which is used for the sampling purpose and other various purpose, because so this is a proximal and this is the direction of the vein. Okay, so this is the direction of the vein towards the our right atrium, right? Yes, sir. So this is the heart we have. Okay, and this is the how a vein will come towards the heart. So this is how the vein will come towards the heart, right? So here, if I am taking from here sample, so it is maybe a like contaminated. I am taking from here, it is maybe a contaminated, we can consider. So the flow is like this. So we will take the first entry only. So that is from the proximal lumen. So the sampling lumen is the proximal lumen. So this is the basic thing you have to understand. And the most importantly, you have to understand that is the distal lumen is used for the CVP measurement, proximal for the sampling, and the middle one for the TPN. So that is the examiner favorite. And this table is the gold standard table for the your Norcet exam. So this is already we have done in the our plan A1. Okay, so we have the distal lumen, that is the 16 gauge lumen. Okay, so this is open at the tip of the catheter and used for the CVP monitoring, right? Yes, sir. So next we have is the so that is the medial lumen or the middle lumen. This is used, this is the 18 gauge lumen and opens between the distal end and the proximal end. So in middle of the distal and proximal, in middle it is opening, and this is a favorite for the total parenteral nutrition. And we have the proximal lumen. So the proximal lumen is the 18 gauge again. So this is opens closest at the insertion site. So here is the insertion site means, so near to the insertion site, which one? That is the proximal. Okay, so question will come. So which lumen is near to insertion site? That is the proximal lumen is the near to insertion site. Okay, so this is for the blood sampling, emergency drugs administration, transfusion purpose, IV fluid infusion rapidly if you want to do, and so this is for the blood transfusion, emergency drugs, blood sampling, and the rapid fluid infusion purpose. We are going to use the our most important, that's the proximal lumen. So this is the very important for your exams. So please do keep in your mind. Okay, and identify this one. What is this? What is this? We have the central lines. So one line we can insert through the femoral. So that is like this, and it will go into the right heart. One is from the right internal jugular. So that will comes here. So that is the right internal jugular vein. And another one is directly from here. That is the subclavian. Okay, so if you are inserting directly into subclavian vein, this is the subclavian we have. This is the subclavian we have. Okay, and if you are inserting directly through the right internal jugular, so this is the right internal jugular vein we have. And the emergency technique we have is that is the femoral. This is the femoral route we have. So these are the primary three central line insertion route. Okay, so one is right internal jugular, another one is the subclavian, another one is the femoral, right? So now you can see here one line which is inserted in the periphery, and this line is continued, and it is ended into our right heart. So what is this one? What is this one? So this is called as the PICC line. So what we call this one is the peripherally inserted central catheter. So that's the PICC line. Okay, so this is the PICC line. Remember the PICC line. This is important for the exam, and the last Norcet, the image based questions have been asked. Okay, so this is already asked image based question. So that's from the PICC line. Okay, they have given the real time image in the exam. Okay, so this is the PICC line we have. That is the peripherally inserted central catheter. So insertion site will be periphery, but the tip will be in the center. So this is called as the peripherally inserted central catheter. Okay, yes sir. So this is very important for the exam. So please do keep in your mind, right? Yes sir. So now the question is, most commonly used vein for the insertion of the PICC line is the my question, and I want answer from the everybody of you. Yes, most common vein used for the central peripherally inserted central vein. Okay, so in the PICC line, most commonly used vein will be, so option will be having the cephalic, basilic, and the cuboidal, many veins. So what is the answer? The most common vein and the first priority vein we are going to use is that is our basilic vein. So this is always the first choice. So please do remember, from here you may expect a question. The most commonly used vein for the PICC line, so that is for the peripherally inserted central catheter, that is the our basilic vein. So this is the very important, please do keep in your mind, important for the exam, right? Yes sir. And here it comes to the all the image based questions. Okay, understand, very basically it is very simple. The catheter which is inserted in the femoral vein, that is near to the groin area, this is the femoral central vein catheter. Okay, and catheter inserted in the periphery, the tip is ended into the end in the center. So this is the PICC line, and the catheter which is coming from the internal jugular vein. So this is the RIJV, that is the right internal jugular vein catheter, and the catheter which is directly inserted from the subclavian and which is entering into the our heart, that is the subclavian catheter. Okay, so these are the image based questions they may ask you in your exam. Okay, yes sir. So next my question is which is having the highest chance of the pneumothorax. We have done that one in the last class, just for your quick revision. So among all this, I told the PICC line, femoral line, and the central line. So that is the RIJV. Okay, and the most important one, that is the PICC line. Okay, so we have discussed the four. Among the four, which one is having the highest risk of the pneumothorax? Highest risk of the pneumothorax? Yes. Which is having the highest risk of the pneumothorax? That is the very nice. So we have the highest risk of the pneumothorax in the subclavian. Sir, how question will come? So question will come, you are inserting a central venous catheter through the subclavian vein to the patient. Like this it may comes. Otherwise, you are inserting the central venous catheter to a patient. Suddenly patient is developing a breathing difficulties, chest pain, and the dyspnea. So that is the difficulty in the breathing. So what you may suspecting here? So if you are inserting the catheter through the subclavian vein and the patient is complaining of the dyspnea and all, so that is you are going to suspect the pneumothorax. Very important scenario based question. It may strike in your exam. Next is, which is having the highest risk of the deep vein thrombosis? Deep vein risk will be highest in which route of the central venous catheter? Yes, that is in a femoral. Okay, so highest risk of the DVT is there in the femoral vein. Okay, next question is, which is having the highest risk of the infection? Which is near to our groin area, that is having the highest risk of the infection. Again, the highest risk of the infection in which central line? So that is mostly and mainly in the femoral. Okay, yes sir. So which is having the highest irritation while walking? Irritation while walking. Irritation while walking. Yes, which route? Irritation while walking is again the femoral. Only emergency route which we have is only we can access in the emergency. Only we can access in the emergency. That is also a femoral. Because there is no risk of the pneumothorax. Which is contraindicated in the emergency? That is subclavian is not allowed in the emergency. Okay, so which one is the most common one? Most common overall route? That is the IJV, that is the internal jugular vein. So which side, sir? Right side, that is the right IJV. Okay, and the next very important golden point to be keep in your mind, that is which one is having the highest irritation while mobilizing the neck. So while moving the neck, which is having the highest irritation, that is again the right IJV is having the highest irritation while moving the neck. And the best for the TPN, best for total parenteral nutrition. So which one is the best for the total parenteral nutrition, sir? That is the our subclavian. Okay, so that is the subclavian is for the TPN. Okay, so this is very important. We are going to revise here. So that is the very important thing to be keep in our mind. Okay, yes. So for the pneumothorax, high risk will be there in the subclavian. Best for the TPN is the subclavian. DVT high risk in the femoral, infection high risk in the femoral, irritation while walking in the femoral. Emergency is the best is the femoral, and the most common overall is the right IJV. Okay, so these are the important and golden point what we have discussed here. Okay, yes. So PICC line we are going to insert for the chemo and various other purpose. We can give the peripheral, the total parenteral nutrition also. So this is very important for the exam. Okay, here it comes to the next question. What is the normal range of the central venous pressure? So let me quickly revise the four very important types of the pressure here, so that you all, every one of you know already this question and answer of this question. So try to give the best answer. What is the normal range of the central venous pressure? What is the normal range of the central venous pressure in a healthy adults? What is your answer? Normal range of CVP in a healthy adults. Yes. Well done. So that is the normal range of the CVP in the healthy adults is the 2 to 8 mm of Hg. So this is very important. Now tell me, leave about the CVP. Now tell me, what is the normal intraocular pressure we have? What is the normal intraocular pressure we have? So which option you are going to choose for the question which is asking you normal intraocular pressure? Yes, that is the 10 to 21 mm of Hg. That is the option A is telling that is the normal intraocular pressure. Okay, yes sir. Now tell me, what is the normal intracranial pressure we have? Normal intracranial pressure. So the pressure which is present inside our cranial cavity, that is the 40 mm of Hg or the 5 to 15 mm of Hg. So that is the C. So C is our normal intracranial pressure. Very important. Please do keep in your mind. Okay. And what is the normal pulse pressure we have? What is the normal pulse pressure we have? So that is the 40 mm of Hg is the normal pulse pressure. Normal pulse pressure is the 40 mm of Hg. Sir, how normal pulse pressure will be 40 mm of Hg? So now tell me, what is the pulse pressure? What is the pulse deficit and what is the pulse pressure? So I will ask the question, you tell me whether there is the pulse pressure or the pulse deficit. Okay. So the difference between the systolic blood pressure minus diastolic blood pressure. So what is this? Pulse pressure or the pulse deficit? The difference between the systolic blood pressure and the diastolic blood pressure. Yes. The difference between the systolic and diastolic blood pressure is the pulse pressure. So the distance between the apical pulse and the radial pulse is the difference which is arising between the apical pulse and radial pulses. What is your answer? Apical pulse I am checking and simultaneously I am checking the radial pulse also. There is the differences arising between these two pulses. What is your answer? What we call that is the pulse deficit. Pulse deficit in the sense the central pulse and the peripheral pulse is showing the difference. Okay, so that's the what we call as the pulse deficit. Very important. Okay, so next comes to the most important. Let me take this one little bit towards the community health nursing. So the today's question I am going to ask you. What is the demographic gap? What is the demographic gap? Demographic gap is the difference between the birth rate and the death rate. So that is the demographic gap. So in a community or in a particular geographic area where the working population is more and the dependent population is less. So what we can call this one? In a particular demographical area we have, in that particular area there is a more working population and very less dependent population, means non-working population is very less. So dependents in the sense the more aged. Okay, so 60 and above. So where they are unable to work, they are dependent on their like income of their son or their daughter or their like caretakers. So the working population is more and the dependent population is less, means that is the demographic gift. That is the demographic gift, right? Well done, beta. Well done, right? Yes, sir. So this is how we are integrating and learning the things. I hope it is clear. Yes. So now tell me how this pulse pressure is 40 mm Hg. So this is very simple. I told the pulse pressure is this is the difference between the systolic blood pressure minus diastolic blood pressure. Okay, so here the systolic blood pressure is how much, sir? Here the systolic blood pressure is 120 mm of Hg, right? So diastolic blood pressure normal we have is the 80 mm of Hg. So the pulse pressure which is arising here is the 40 mm of Hg is the pulse pressure. So this is the very important for your exams. Please do keep in your mind, this is examiner favorite. This is the examiner favorite. Okay, so that is normal pulse pressure we have is the 40 mm of Hg. Okay, so now tell me what is the a formula to calculate cerebral perfusion pressure. So cerebral perfusion pressure, tell me the answer how you are going to calculate the cerebral perfusion pressure, and you give the answer for this question what I'm asking now here. Okay, so yes, so in the question examiner mentioned there is in the 120 mm of Hg is the SBP we have, and 80 mm of Hg is the diastolic blood pressure we have, and intracranial pressure we have is the 10 mm of Hg. So now you tell me cerebral perfusion pressure, how much is the cerebral perfusion pressure? Try to tell the answer for this one. We have the SBP 120 mm of Hg, DBP 80 mm of Hg, intracranial pressure 10 mm of Hg. What is the cerebral perfusion pressure? So can I give the clue to you all? Yes. So who all know the concept, give your answer. So who don't know the concept, understand with this clue. So the cerebral perfusion pressure we are going to calculate, that is the mean arterial pressure minus intracranial pressure. So this is the how we are going to calculate the cerebral perfusion pressure. Yes, try to give the answer. Mean arterial pressure minus intracranial pressure. So to get the cerebral perfusion pressure, first you have to calculate the mean arterial pressure. So the whatever the answer is coming out of the mean arterial pressure, you are going to calculate with the, we are going to deduct with the intracranial pressure. Okay, so let me calculate. First, how I am going to calculate the mean arterial pressure, that is the map. So map in this is equal to, that is 1 into SBP plus 2 into DBP divided by the 3, right? Yes, sir. Sir, how much is the SBP given in the question? So that is 1 into SBP is the 120 mm Hg plus 2 into DBP is the 80 mm Hg and divided by the 3, right? Yes, sir. So now you calculate, you will get the map. Okay, so how much it is coming? The mean arterial pressure is equal to, that is the 120. So here plus 2 into 80. So that is how much? That is the 160 divided by 3, right? So let me divide this one. So that is the 3 1 ja. So this is here I will cut it. That is 3 4 ja. So this is a 40. Okay, so that is now, no, this is something went wrong here. 3 1 ja. So this is the 3 4 ja. So that is the 40. Okay, so 40 plus 160, which is about 200. Okay, so 200 minus, we are going to deduct the ICP, that's the 10. So this is, no, map will not come this much high, right? So yes, something went wrong here. First we are going to make the multiplication, then the division. So that is, first we have done the then first we are going to make the division. Okay, so 3 1 ja. So this is the, what we have is the 340. Okay, so this is 40 plus 2 is the 42. No, this is also going to again double. Let me take a help of the calculator. Something is mistake in the calculation. Okay, so let me take that one. Okay, yes, so give me a second. That is now calculate 120 into, sorry, plus. So this is the plus how much we have? that is the 80 into 2 divided by 3. So that's the 173. Okay, so this is 173 minus we are making here is the, so that's the ICP we are removing from that one, and how much answer will come, so you do comment in that one. Okay, so you do the calculation, that is first calculate the map, then remove the ICP from the map, so that will be our cerebral perfusion pressure, that will be our cerebral perfusion pressure. Okay, so you do comment that one. I will take the same question in the next class. Okay, I will give the one question for the practice also. Right, here it comes to the next question. When performing the CVP monitoring, the position of the patient should ideally be, what is the position of the patient ideally when performing the CVP? So that is, we are inserting the central venous pressure. Okay, CVP line we are inserting. The ideal position for this patient is, we are not inserting the CVP here, so just we are monitoring the CVP. So in the inserting the CVP, they will directly mention while inserting the central venous pressure. So they have given clearly here, that is the while performing the CVP monitoring. So here we are monitoring the pressure, how much pressure is there inside the our central venous, we are monitoring it. Okay, so while monitoring the CVP, what is the ideal position is this one? So that is the question. What may be your answer? Option A, that is supine with the head of the bed elevated 30 to 45 degree. Supine with the head of the bed elevated 30 to 45 degree. This position we are going to provide. Option B, sitting upright with a 90 degree angle. No, this will give the abnormal high CVP. And option C is there, prone with the head turned to the opposite side. So prone is the not recommended position to monitor the central venous pressure. Lying flat with a no elevation of the head, also wrong. So the ideal position to monitor the central venous pressure is, we will give the supine position with head of the bed elevated of the 30 to 45 degree. So this is the correct answer. Okay, so here we have the correct answer. That is the supine with the head of the bed elevated 30 to 45 degree is the ideal position for the central venous pressure monitoring. Okay, and so the next question here it comes. Yes, the very important and basic question, and the concept behind this question is also very important. Okay, so try to understand what is the potential consequence we have often not aligning the transducer with a phlebostatic axis is the question. So you are monitoring the CVP. So during the central venous pressure monitoring or during the measuring of the central venous pressure, you are not aligning the transducer with a phlebostatic axis. So what is the potential consequences we are going to face? So this is the question. Option A, it may result in falsely low or falsely high readings due to the hydrostatic pressure. Okay, then option B, it causes the immediate blood pressure spike in the patient. Option C is, it leads to inaccurate blood gas measurements. It's not a relation with the question, so I am eliminating the C here in the one shot only. And option D, it will be causing the catheter dislodgement. So what is the potential consequences? So the basic concept we have to understand here is, so this is how we are going to measure the central venous pressure. Here we have the manometer. This is the manometer. We have the two techniques, one by the transducer, another by the manometer. Okay, so among the both, the transducer method is the gold standard one. Okay, so this is the manometer we have. So this is used for the measuring the CVP. Okay, the zero of this manometer, this one will be the zero of this manometer, or we can say the transducer also we can keep at this level only. This is the transducer level, or we can say zero of the manometer, zero of manometer. This must and should be at the level of the phlebostatic axis. Sir, what is the phlebostatic axis? Where it will be, sir? This will be in the fourth intercostal space. This is the 1, 2, 3, and this is the fourth. Okay, in the fourth intercostal space, that is in the mid of the axilla, mid axillary line. This is the phlebostatic axis. That is fourth intercostal space, mid axillary line. Here, the correspondence of the phlebostatic axis will happen. Yes. So this is a phlebostatic axis which happens. Okay. So the zero of the our manometer and the transducer which we are fixing here, it should be equal to the our phlebostatic axis. That is at the level of the fourth intercostal space, mid axillary line. Why? Because in the phlebostatic axis level only our right atrium is present. So right atrium is present in the phlebostatic axis level only, that is in the fourth intercostal space, mid axillary line. So exactly at the level of the our this particular right atrium, that is fourth intercostal space, mid axillary line we want. So this is a most important, we have to make sure. If in case this zero or the transducer is high, means the value will come low. If this transducer or the zero is low, means the value will come high. Okay, if it is high, the value will be low, and if it is low, the value will be high. So in order to make sure the value should be accurate, this should be equal. So in the question what they have asked, in the question they have asked that, so that there is no alignment, there is no equalizing is there between the our transducer and phlebostatic axis. If it is not aligned, if it is high or low, means so it may results in falsely low or the falsely high reading due to the hydrostatic pressure error. Okay, due to the hydrostatic pressure error, it will show the falsely low or the falsely high value. So this is important for the exam. Please do keep in your mind and understand what is the exact level of the our phlebostatic axis, that is the fourth intercostal space, mid axillary line, and where exactly our right heart, so that is the right atrium will be locating. Okay, and the transducer or zero should be at the this level. Okay, and which instrument which we are using for the measuring the CVP, that is the manometer, and the transducer is the gold standard one. Okay, so which we have already done in the plan A1. Okay, here it comes to a beautiful and a very beautiful motivational line. So that is, dear students, yes, we know it's hard to take the first step for our study, but once you take it, you will learn and you will end up with lots of the learning. So that is with the complete clarity. Okay, so just take a first step towards your preparation. Study hard, study with your full extent, and try to understand the concept and build the concept, practice the concept. That is going to make you a champion. Okay, yes. So yes, the studying the thing is not a part of the everybody's life. So many people, they will get sleep, even they will open the book. Okay, so it is for the champions. So you all are the champions, you all are completely involved in the best learnings, because the studying the book is not that much easy. So we will study lots of the book is not that much easy. You people will directly watch the classes and you will grip the concept. So the filtering the concept from the book is hard. So that is only for the champions like you. So you study hard, you work hard, and the better result will be definitely comes with your side only. Okay, yes. So here it comes to the next question. So that is the most important and the very important question. This is very important for the exams. Yes. As per the latest advanced trauma life support guidance, what is the correct site of insertion of the chest tube in a trauma patient is the question. In a trauma patients, what is the correct site of insertion of the chest tube is the question. Option A, second intercostal space, mid clavicular line. So this is the old concept where we are using to we are going to follow to convert the tension pneumothorax into the simple pneumothorax. So that is second intercostal space, mid clavicular line, anterior chest. So this is the old concept. Now for converting the tension pneumothorax into simple pneumothorax also, the ATLS guidelines is not recommending the second intercostal space. mid clavicular line. Why? Because here in the anterior chest we have the pectoralis major muscle, pectoralis minor muscle, and like beneath of that one we have the intercostal muscles. So crossing these muscles is not that much easy. Okay, so major, minor, then sorry, the pectoralis major, pectoralis minor, and the intercostal muscles, you are crossing, and you are going inside. So that is not that much easy process because of the heavy and bulky muscle mass which we have in the anterior chest. So that is the reason it is not recommended in the emergency now, and the ATLS guidelines for the conversion of this tension pneumothorax into simple pneumothorax also, they are not recommending this one. So this is not in the no more, it is the answer for anything. Okay, then next comes to the option B. So that is the fifth intercostal space, anterior mid-axillary line within a triangle of the safety is the option. And this is the perfect answer for the chest tube insertion in a trauma patient. The best site is the triangle of the safety. That is fifth intercostal space, anterior to mid-axillary line. Anterior to mid-axillary line means just in front of the mid-axillary line. So you can see here we have the triangle of the safety. So just then option C I am eliminating, it is the third, so it is not and the correct answer. And the ATLS guideline says don't go behind the 6. If you are going beneath the 6, you may damage the intra-abdominal organs. Okay, so the sixth intercostal space is nowadays not recommended because here there is a chance of the intra-abdominal organ damage. Okay, so the sixth intercostal space is nowadays not recommended because it is having the intra-abdominal organ damage risk. Okay, so the correct answer is the fifth intercostal space, anterior to the mid-axillary line, that is the within triangle of the safety. So you can see here the answer for this one, the chest tube insertion site, as per the updates and the latest guidelines, what I have told in the plan A1 with the complete updated guidelines, that is the chest tube insertion is recommended in the safety triangle, is the first priority answer, is the safety triangle. So that is where it is exactly, sir. It is between the fourth and fifth intercostal space, just anterior to the mid-axillary line. Okay, so this is the axilla and this is the mid-axillary line, just anterior to this one. So that is the anterior to the mid-axillary line is the exact site where you are going to insert the chest tube. Sir, you told about the triangle of the safety or the safety triangle. Sir, how we are going to mark the triangle of the safety or the safety triangle, sir? So this is having the boundaries here. So these boundaries of the safety triangle is important. So the first boundary which is having is the front side. So this is the anterior of the our anterior portion of the our chest. So that is the what we can say, anterior border we can say. So this is made up of the, here we have the pectoralis major muscle. Okay, this is the lateral border of the pectoralis major muscle. Yes, this lateral border of the pectoralis major muscle is the anterior boundary. Okay, yes, and here we have the latissimus dorsi muscle. Okay, here the lateral border of the latissimus dorsi muscle. So this is the our again the back side portion of the posterior boundary which we have, and the lower down, that is the inferior boundary which we have, is the, that is the imaginary line which is drawn from the fifth intercostal space or from the nipple line. Okay, so from the nipple line or from the fifth intercostal space we are drawing the imaginary line. So that is our inferior boundary. So here this particular space is now the triangle of the safety. So where this one which is inserted inside is the chest tube. Okay, so chest tube is inserted in the triangle of the safety. Okay, so this is very important for the exam, right? Yes, so I hope it is very much clear to every one of you regarding the triangle of the safety. So here it comes to the next question, the question which I have already cleared in the first question itself. So that is asked here. So try to get the best answer. When inserting the needle for the tension pneumothorax, that is the needle decompression in the tension pneumothorax, the preferred site is option A, the mid-axillary line. at the fourth intercostal space. This is not going to be a pure correct answer, so I'm keeping this one in the side, and I'm going to the next option, that is the anterior chest at the second intercostal space, mid clavicular line. This is as per the old guidelines. This is as per the old guidelines. This is as per the old guidelines. Okay, so then option C, we have the posterior chest at the 8th intercostal space. 8th, I told, if you are going beneath the 6 only, that is you are going to damage the intra-abdominal organs. So here it is written the 8th. So this is not a correct. So I am eliminating the option C also. Then comes to the option D, that is the 5th intercostal space anterior to the mid-axillary line. So this is the now correct answer as per the new guidelines. Okay, as per the new ATLS guidelines, the correct answer for the needle decompression in the tension pneumothorax is the, so again, the 5th intercostal space, that is anterior to mid-axillary line, is the correct answer. Sir, why the old one is removed? I told the old one is, that is in the anterior chest, second intercostal space, mid clavicular line, middle of the clavicle, second intercostal space, anterior chest. Here the muscle mass is more, it is difficult to prick the needle and to get remove the air here. So that is the reason this is now removed. Now we are following the again the 5th intercostal space anterior to mid axillary line. So this is the best answer as per the new guidelines, and you follow for the next Norcet this one only, and this is only going to give a marks in the next Norcet. Okay, so please do keep in mind, right? Yes. So now you tell me what is the tension pneumothorax and why we are going to go for the needle decompression here. Understand. So tension pneumothorax is, so this is, we are having the lungs. Okay, so let me make a lung. Okay, this is the lung we have. Okay, so the 3 lobes of the lungs we have, and this lungs which is covered by the a membrane. So this is our pleural membrane. Inside this pleural membrane, so there is the accumulation of the air. Okay, yes. If this air is coming here and it is going back, coming here and going back, that is the simple pneumothorax. If in case air is accumulating here, but it is not escaping, so that is what you can call as in the tension pneumothorax. So if it is coming here and if it is accumulating and which is not going out, so which is building pressure here only, so this is going to collapse the lungs within a minutes or the seconds, which is going to collapse our lungs within a minutes or seconds, right? Yes. So the air is entering and which is not going back, so that is called as the tension pneumothorax. So what we can call that one? So we can call this one as in the tension pneumothorax. So what is the tension pneumothorax? Air is entering but not escaping. So that is the tension pneumothorax. Here it is in the very important severe medical emergency, because here it is collapsing the lungs as a vital organs, it is collapsing and it is performing the mediastinal shift to the opposite side, tracheal division to the opposite side, and which is creating the pressure over the heart also. So that is the reason this is the medical emergency, where immediately I am going to insert the needle and I am going to relieve this pressure, and I am going to convert this particular this tension pneumothorax into the simple pneumothorax. Okay, so the temporarily I am going to convert this tension pneumothorax into the simple pneumothorax. Okay, sir, how we are going to convert this one? By the needle decompression, by the needle decompression. Sir, is this enough to convert the simple pneumothorax and tension pneumothorax into simple pneumothorax? No, it is not in pneumothorax. So it is not in the, it is not in the enough. So we are going to go for the definitive treatment. So tension pneumothorax was the medical emergency. We have done the needle decompression, converted the simple pneumothorax. Now we are going to insert the chest tube drainage, so to drain all the air which is accumulated in the our pleural space. So the definitive management is again the chest tube drainage. So only for the converting the tension to the simple, so we are going to perform the needle decompression. That is the only emergency and the temporary management. Okay, yes sir. So previously for the needle decompression, we are using the second intercostal space. Okay, so mid clavicular line, that is on the anterior chest. Okay, that is on the anterior chest was the a site of performing the needle decompression as per the old guidelines. Now we are not following this. Now we are not following this one. Now we are following the, that is what I told, between the fourth and fifth intercostal space. Okay, that is anterior to mid axillary line. So here, because of the less muscle mass we have, and we can easily insert, and the risk of the other organ damage is also very less. So that is the reason this is the most recommended. Okay, yes sir. So I hope it is very much clear, right? Now the question is here. Sorry, try to give the best answer for this question. Triangle of the safety is concept used for the chest tube placement. Which of the following is not a boundary of the triangle of the safety is the question. So try to give the answer for this question. The triangle of the safety is the concept used in the chest tube placement. Which of the following is the not a boundary of the triangle of safety is the question which is asking here. So try to give the answer for this one. Yes, well done. So that is D is not a part of the our triangle of the safety. So we have already discussed this one, right? Yes, the lateral border of the pectoralis major muscle and anterior border of the latissimus dorsi muscle, and the fifth intercostal space, the nipple line, imaginary line. That was the things which is making the triangle of the safety. You can see here better clear. Okay, so here we have the triangle of the safety. You can see. So front we have the pectoralis major muscle. So this is the pectoralis major muscle, means this is the lateral border of the pectoralis major muscle, and the inferiorly, that is the imaginary line which we are drawing from the nipple line or from the fifth intercostal space. That is the inferior boundary. And here we have the latissimus dorsi. So this is the anterior border of the latissimus dorsi. Okay, anterior border of the latissimus dorsi. That is the lateral edge or the anterior border of the latissimus dorsi is the for the inferior border. Sorry, that is for the posterior border, and the anterior border is by the lateral edge of the pectoralis major. So this is the anterior, means this is the front, it is the anterior, right? So this is our anterior portion. So anterior border is made up of the lateral edge of the pectoralis major, and that is the back side, posterior. So that is by the anterior edge of the the anterior portion or the anterior border of the latissimus dorsi, or the lateral edge of the latissimus dorsi, we can say. Okay, so that is a side edge of the latissimus dorsi, that is the anterior portion of the latissimus dorsi. Okay, and here the down we have is the fifth intercostal space. Okay, so this is the making a triangle of safety. This is the best site for insertion of the our chest tube drainage tube. So this is the image based question. So what is this? This is only what we are discussing till now. Okay, so regarding this only we are discussing till now. This image based questions may directly strikes on our in your exam. What is this? Yes, this is only the chest tube drainage tube. So this is the chest tube drainage tube. Okay, so this is our chest tube drainage tube. Very important. Okay, so image based question may strike, so please do remember. Next we have the question here. A continuous excessive bubbling is happening in the water seal chamber of the chest tube. So in the chest tube system, so there is in the water seal chamber is there. So in the water seal chamber, there is in the continuous bubbling is happening. Continuous excessive bubbling is happening in the water seal chamber, not in the suction chamber. in the suction chamber, in the wet suction system which we have the dry suction and the wet suction system. In the dry section there is no bubbling, that is okay, that is normal. And the wet suction chamber, there is the gentle bubbling is normal. But the question is not about the suction chamber, the question is about the water seal chamber. In the water seal chamber, there is the continuous excessive bubbling is happening. What it means? Continuous excessive bubbling in the water seal chamber, which indicates option A is the chest tube is functioning correctly. No, the chest tube is functioning correctly means there is an intermittent bubbling, not the continuous. Okay, there is the intermittent bubbling will be there. There is no continuous bubbling. Okay, so if chest tube is functioning normally perfectly, there is the intermittent bubbling will be there. That is the normal. Okay, and option B, we have there is an air leak in the pleural cavity or the chest tube system. So yes, if there is in the continuous excessive bubbling is there in the water seal chamber, which clearly indicates there may be in the air leak in the pleural cavity or there may be in the air leak in the chest tube system. So this is what actually the meaning of the our continuous excessive bubbling in the water seal chamber. Okay, so continuously excessive bubbling happening in the water seal chamber, which indicates the air leakage. Remember, intermittent bubbling is the functioning correctly and this is the normal, and just we are going to document that. And if air leakage is happening, continuous excessive bubbling is happening in the water seal chamber, that is going to inform to the physician immediately, and we are going to clamp the chest tube and we are not allowed to go the external air back into the our chest tube, our pleural space. Okay, so we don't want the like external air to go into the pleural space, so we will immediately clamp the tube. Okay, next we have there is in the pleural space is fully re-expanded. So if the pleural space is fully re-expanded, that time there is no tidling. There is no tidling. Okay, so this is not a correction. So I will teach what is the tidling also. Okay, don't worry. Next we have the option D, the chest tube is closed. So this is also not a correct answer. So correct answer for this one is the option B. Okay, yes. The next very important thing we are going to keep in our mind. So that is intermittent bubbling in the, you write this one, so otherwise you will get confused in the exam. So that is the, we are having the bubbling. Where, sir? We are having the bubbling in the water seal chamber. Okay, water seal chamber. And bubbling in the suction chamber. In the suction chamber. In the suction chamber, in a wet suction system, gentle bubbling is normal. Gentle continuous bubbling is normal. It is purely normal. In the suction chamber, gentle continuous bubbling is normal. Okay, so this bubbling in a water seal chamber, it indicates the two things. So that is, in the water seal chamber, there may be in the continuous bubbling or there may be in the intermittent bubbling. Okay, sir, if there is in the intermittent bubbling, if there is in the intermittent bubbling, this indicates an normal function of the our chest tube drainage tube. Okay, if in a water seal chamber there is a continuous bubbling, this indicates a most important air leakage. The air leakage which is happening from the chest tube system or from the pleural space. So this is the very, very important concept you have to keep in your mind. Remember, in the suction chamber, gentle continuous bubbling is the normal. Okay, and in the water seal chamber, intermittent bubbling is the normal, continuous bubbling indicates the air leakage. So this is the concept to be keep in our mind. Okay, so next we have is this one. When the chest tube is dislodged from the site of the insertion, what the nurse should do here is the question. So we have the patient with the chest tube. So that particular chest tube is dislodged from the insertion site. What the nursing officer should do here? Option A is there, leave the tube out and allow the air to reabsorb naturally? No. So the main purpose of the insertion of the chest tube is to replace the or all the negative pressure which is there in the pleural case. Okay, so usually normally we will be having the, so this is the lungs you consider, this is not a lungs, so this is the lungs you consider. Okay, so and this is the pleural cavity you consider. Okay, this is the pleural cavity just to consider. So I will take a little bit big. Okay, this is the pleural cavity you consider, right? So this lungs will be kept expanded by the our negative pressure which is there in the our pleural cavity. The pleural cavity is normally having the negative pressure. Okay, yes sir. So if something which is getting breaking in this particular pleural cavity, okay, that time this will lose its complete negative pressure and it will be filled with the external air, and this will create the positive pressure here, and this positive pressure will create the pressure on the our lungs. So that time what happens to the lungs? Lungs will start to, this particular lungs will start to collapse. Okay, this one will start to collapse. So now what is our main purpose of the chest tube insertion? So the chest tube insertion main purpose is we want to remove this positive pressure from here. Okay, we want to remove the positive pressure and we want to rebuild the negative pressure. Okay, we want to create and rebuild the negative pressure. So if we are creating the negative pressure back, again our lungs will be completely expanding back. Okay, so now the lungs will completely expand back. So for this one, what we are going to do, we are going to insert the chest tube drainage. So this is the main purpose of the chest tube drainage, is to replace all the negative pressure in the pleural space and remove the positive pressure which is abnormally accumulated in the pleural space, is the our main purpose. Okay, yes sir. So now we have inserted the chest tube. This chest tube is accidentally came out, dislodged from the site of the insertion. What we are going to do now? So here you will get the two very important type of the situation. So one is, you consider this is the, I will first label the thing, then you will get the complete clarity. This is our chest tube. This is our chest tube, and here you can see this is this pipe. This is the drainage tube what we have. This is the drainage tube. Okay, and here we are having the chest tube drainage system. Okay, yes sir. So this is the site of insertion. This is the site of insertion of the chest tube. This is site of insertion. Okay, yes sir. Now the two situation will come. One situation is this particular chest tube which is dislodged from the site of insertion. What you are going to do? From here it is came out. That maybe comes as a patient pulled it out, or while changing the position it came out from the site of the insertion. So the question is, from the site of the insertion chest tube is dislodged or which is coming out, which means we are going to pinch the skin here. Okay, and immediately apply the occlusive dressing and not allow the external air go into the our pleural cavity. That is the intervention. So what we are going to do, when the chest tube is dislodged from the site of the insertion, pinch the skin and cover with the occlusive dressing. If in case this is the chest tube which we have and this is the drainage tube which we have, so here we connected between the chest tube and drainage tube. This is accidentally get disconnected. This one is accidentally get disconnected. What we are going to do? So this particular chest tube tip which we have here, this is disconnected, means this tip we are going to dip into the normal saline box. So that is the reason whenever you are taking care of the patient with a chest tube, always you are going to keep one normal saline bottle, so that is which is cut, so that a normal saline bottle you are going to keep at the bedside. If this is accidentally disconnected, that this particular tip should be entered into the water. So if you are entering this particular tip into the water, means it will not allow the environmental air go back into the our pleural cavity. So in order to prevent the environmental air to go back into the pleural cavity, we are entering this, or we are covering this particular tip of the chest tube in the normal saline bottle. So that is the reason whenever you are taking care of the patient with a chest tube insertion, keep the one normal saline bottle, which is upper portion of that particular bottle should be removed, and only which will be kept ready to dip. Okay, so that's the very important. And another situation is, so that is this particular system is broken, then what we are going to do? So that time we are going to immediately enter this chest tube into our water seal chamber, this in our normal saline bottle, and we will remove this one and we will replace with the new one, is our nursing intervention. So these questions to be asked in your exam. Very simple. So in our question, what it is asked? It is asked that it is dislodged from the site of the insertion. It is means from the site of the insertion, the tube is came out. So what is the intervention I told? That is option A, leave the tube out, allow and for the like reabsorption of the air naturally. No, this is not in the correct. I'm eliminating the option A. Then comes to the option B, immediately insert the new chest tube in the normal saline. Okay, so this is like the tip of the chest tube, not a new chest tube. The tip of the chest tube which is there in the chest, so that is in the pleural cavity, that is going to enter into the normal saline when it is disconnected between our chest tube and the drainage tube. So it is not get disconnected between the chest tube and drainage tube. So now it is dislodged from the site of the insertion. Then the answer goes to seal the insertion site with a sterile occlusive dressing is the correct answer. So this is the correct answer. Okay, so if the question is coming like this, we are going to respond. Okay, so I hope it is clear. So if it is disconnected between the chest tube and drainage tube, tip of the chest tube should be entered into the normal saline bottle. Okay, and dislodged from the site of the insertion, occlusive dressing is the priority. So I hope it is very much clear to everyone of you, right? Yes. And identify this particular image which is there here. Okay, so you can see here also we have the same that image which we are using here, and that is the image, this one. Okay, so what is the name of this image? So this is your question here now. So identify this image and what is the purpose of this one. I am going to explain. What is this image? Yes, this image we are going to call as in the Hamlich valve. So what is this one? This is the Hamlich valve, or we also call this one as the pneumostatic valve. So what we are going to call this one? This is called as the pneumostatic valve. Sir, where we are using this one? We are connecting this one between the drainage tube and the chest tube. So here we have the chest tube and here we have the drainage tube. Between the chest tube and drainage tube, we are connecting our Hamlich valve or the pneumostatic valve. If in case accidentally disconnection happened between the drainage tube and the chest tube, so that time this Hamlich valve or the pneumostatic valve, it will not allow the environmental air to enter into the pleural cavity. So this is the very important main purpose of the Hamlich valve. So what it will do? It will not allow environmental air to enter the pleural cavity. It will not allow to enter the pleural cavity. So this is the main purpose of our Hamlich valve or the pneumostatic valve. So where we are using this one, sir? We are using whenever we are shifting the patient from the one hospital to another hospitals. So in the vehicle, in the ambulance, and also there is high risk of the disconnection is there between the chest tube and the drainage tube. So that time we are connecting the Hamlich valve between the chest tube and drainage tube, and we are sending the patient to or we are transporting the patients with the high security. So that is the very important thing to be keep in our mind. Okay, yes. So the next question is this one. If there is no tidalling in the water seal chamber, so in the water seal chamber there is no tidalling. What is the tidalling, sir? So there is whenever the patient will take a deep breath, the water will move up, and whenever the patient will exhale, that time water will come down. So it should be water will go up, down, up, down, up, down. So this is called as the oscillation or the tidalling of the water. So in the water seal chamber, right? So now in the water seal chamber there is no tidalling. What it indicates? So this, whenever the patient is inhaling, that it is not coming up. Whenever the patient is exhaling, it is not going down. So there is no tidalling in the water seal chamber. So what it indicates? Option A, maybe a possible blockage in the tube or the drainage system. Option B, complete pneumothorax. Option C, the presence of the large pleural infusion. Option D is the dislodgement of the tube. What it indicates? Yes, so whenever there is in the kinking is there, blockage is there in the tube, so that time there is in the articulation will get stopped. Otherwise, whenever there is in the completely re-expansion of the lung is happening, that time the articulation is going to stop. So here there is in the no tidling or the no articulation means the tube is blocked. So just we are going to inspect the entire length of the tube, whether it may be a like stuck under the patient body or whether it may be a kinking. So that one we are going to relieve. Okay, so if there is no kinking, no lumens, what it indicates, the lungs are completely re-expanded and it comes to the normal. So then we are going to take a X-ray and we are going to confirm the complete re-expansion of the lungs. So now here in the option there is no re-expansion of the lungs, the answer goes to the possible blockage in the chest tube, or it is maybe a possible blockage in the drainage system. So this is the very important to be keep in our mind. If there is no tidling in the water chill chamber, so which indicates the there is a blockage or there is in the stucking in the tube. Okay, yes. Next is this question. The main primary purpose of the Minnesota tube. What is the main primary purpose of this one? So this is your assignment question. So I hope you people have been enjoyed a lots in this particular class, and that cerebral perfusion pressure. So that is the next question. So what I'm discussing after this question in the next class. Okay, so we will not leave that much easily. Okay, so that I'm going to discuss again, and don't forget to revise the entire topic what we have discussed today. So the notes of this particular class you are going to get in the A1 and A2 plan both. Okay, so from there you just revise the entire notes what I have given here. Okay, and don't forget to mention answer for this particular question. And I hope you enjoyed the today's session. We have covered the things which we have left in the last 2 days. Okay, so along with that one we have covered the today's thing also, and tomorrow also is going to be a huge and a beautiful session. So last 2 more days, the fundamental of nursing, all the important things to be I'm going to cover, and I am going to wind up. Then after that we will go for the community, then psychiatry, pediatric. Okay, so I'm going to wind up for our prelims. Okay, then after that we are going to continue with the again golden points for the mains. Okay, yes, so the OBC important topics also I will try to cover. Don't worry about it, that one. Okay, yes, so main focus is on the revision of the notes plus this class and the golden points. Okay, so that is more than enough, right? Yes, so don't forget to give the today's live mains test. So the live mains test is exclusive for you only, and if you have any doubts, so ask in the app chat box and do mention in the comment also. Thank you so much for watching till here. We will meet again. Okay, so tab tak ke liye Jai Hind, Jai Bharat. Take care and be confident. Everything is going to come you in a correct time, in a correct situation, and which is going to make you in a correct position which you are dreaming for. Okay, yes, stay connected, keep learning, and which we are posting a few very important MCQs on the Telegram channel. So that is a very important frequently asked question we are going to post on the Telegram channel. So that is you are going to solve every day. So don't ignore those questions also, because those are very important and very frequently asked question I am posting in the Telegram channel. So do join there also and give the daily 10 question early morning whenever you will wake up. So solve those questions, and otherwise while sleeping you do solve that question. So just revise one time immediately after solving, that is enough. Okay, yes, so we will meet again with a beautiful session tomorrow again. So if any one of your friends are preparing for the future exams, so we have the best plan in our app, so please do recommend that one also. So bye bye, take care, we will meet again in the next class. Jai Hind, Jai Bharat.